So my name, for those of you who I haven't met or seen before, I'm Dana Mitchell. I am with Mountain Pacific, and I am the nursing home account manager supporting the nursing homes in Alaska and Hawaii. And today I'm really pleased to introduce the two speakers that we have today. First up is the Alaska SSA. I flew all night, Matthew. Help me out here. Our state survey agency. The lead of our state survey agency, Matthew Thomas. And I've been working with Matthew for ever since he started as a baby surveyor. And now he's leading the office. And he has proven to be a really strong partner for the nursing homes in Alaska. He's very willing to share his views, how he interprets mandates, where we're at with, if the state is still working on things. He's very open with where folks are at. So he's going to talk a little bit in the beginning. And then we have Dr. Kunzweiler, who is Mountain Pacific's medical director. He's a retired ER doc, and he is based out of Helena. So we have a couple of really great guys on today. So take it away, Matthew.
All right, thank you. I'm going to turn off my camera just so I can focus on the presentation. Dana, can you just validate you can still hear me okay?
Yes, I can hear you fine.
Excellent, thank you. Thank you guys for attending today. I'm really excited to talk about vaccine requirements. We're going to do a general overview, and the goal is for you to know that there's multiple components to what CMS is requiring, as well as we'll break down a little bit. And then we'll also even get to the surveyor side. You'll be a surveyor for a little bit of the presentation, and you get to see the scope and severity and how we determine how bad a citation may be. So if we can go to the next slide. Again, my name is Matthew Thomas. I'm the state survey director for Alaska. Here's one of our beautiful pictures from up here in Alaska. And I'll have contact information at the end if you need it. Next slide, please. It's very important that I need you guys to understand this presentation does not reflect the opinion of CMS, nor does it replace any law, regulation, QSO, memo, or statute. I do highly suggest that you follow all directions from CMS and from their documentation. This is only an informational session. Next slide, please. And I've also supplied the resources to which I'm getting the information from, QSO 2207, 09, and 11. And if you go to the next slide, you'll see why there's 3. So CMS gave everybody a 30, 60, 90-day compliance timeline. And if you were not part of the list in the December 28 line there, then that means that your full compliance date would have been March 28. For I think most of us in this, or a lot of us in this meeting, our compliance date is the January 14, 2022. Which we will have to be in full compliance by April 14. And then Texas, they're on their own. They took a little longer, so their compliance date's the 20th for all vaccine requirements. And next slide, please. Okay, let's get down to the meat and potatoes of what CMS is requiring. It's not just as simple as having 100% vaccination. You also have to have the policy and the procedures. So I'm going to briefly go over the subsections of policy and procedures and entertain any highlights that are necessary in which you should be very aware of. So the first requirement is vaccine administration. So you have to ensure that all your staff are either vaccinated and or have an appropriate exemption or delayed medical reason. If you have those individuals who are not fully vaccinated or on a medical delay, temporary delay, I believe is what they call it, then you're also required to do a little bit more, go above and beyond what you normally would with individuals who are vaccinated. And I've included some of those examples here, maybe reassigning somebody who's maybe a ward clerk who's on the unit, maybe he or she can work outside of the unit. And Lori, I have no problem with sharing slides, so yes, that'd be great. And if you also look at CDC, there's also additional suggestions that they make for you guys to do, such as N95s or goggles or so forth, that are a little bit more stringent than someone who's vaccinated. And that also includes weekly testing. I do want to make a good point that a lot of people are missing this, is that CMS does encourage you to contact your local Department of Health for assistance with information like additional precautions. For us, it's our state epidemiology department. In your state, it might be somebody different. Next slide, please. This one I think is probably going to be one of the hardest yet easiest at the same time. Depends on how your facility is set up. You're supposed to track vaccine status for all of your employees. And that includes vaccine status, booster doses, exemptions, any special requirements that the facility puts on its staff that's separate than what the state and federal government may do. And you also have to track the temporarily delayed ones. And that's what I was calling medical delayed. And we'll get a little bit into that later. But you need to have a sufficient tracking, because that's going to be part of your compliance when the surveyor shows up. Next slide, please. And then we're going to get into the topic of vaccine exemptions. So you have to have a process in which your staff may request an exemption, how it will be evaluated, and how it will be granted or denied. This process needs to be very clear, because we as surveyors, I'll talk about this again later too, we as surveyors will not look at the exemptions themselves. We're really going to hone in on your process. And if your process has hiccups in it, then that's when you're, at risk for a citation. And then, I do want to point out the note here at the bottom. Staff who are unable to furnish proper exemption documentations must be vaccinated, or the facility must follow the actions as if they were unvaccinated. So documentation is very key here. Next slide, please. Okay, so I'm not going to get too deep into medical exemptions and religious exemptions, but I do want to point out a couple identifying factors I think some people may have been missing. When you do a medical exemption, you are required to document the COVID vaccine that is clinically contraindicated and the reasons for that contraindication. I think that's being missed in certain aspects of surveying facilities. And you also must have a provider signed document by a licensed practitioner acting within their scope of practice to be able to give that exemption. I don't know why CMS felt like they need to put this next section in, but I figured it was important. So the individual who signs the exemption cannot be the same individual requesting the exemption. So a medical doctor cannot sign his own exemption. Next slide, please. In addition to that, as I mentioned earlier, you have to track and secure documentation for the vaccine status, and that includes your medical exemptions or temporary delayed. CDC does have a list of scenarios where you might be clinically delayed to receive that first or second or that booster shot. So I've offered you the temporary delayed vaccination definition here. Next slide, please. So non-medical, this includes religious exemptions. So they actually have some pretty specifics on what you need to do for those exemptions. And they must be evaluated and documented according to federal law and policies. And CMS directs, this is something I learned actually when I made this presentation. There's the EEOC compliance manual on religious discrimination, and it has information on how to evaluate and respond to such requests as religious exemptions. So I thought that was really important for everybody to know. Next slide, please. So this is really what I really want to push to people, and I want everybody to know because we want to be transparent. We will not look at the exemptions themselves or the rationale for the facility's acceptance or denial. However, we will scrutinize your process to make sure it's intact and contains all the elements and that you're executing it appropriately. Next slide, please. Okay, I believe this is the last section of the policy and procedure elements. And this is a contingency plan. This is pretty important. You need to have a contingency plan as if you had, let's say, nurse A come up to you and say, I refuse to be vaccinated. I refuse to apply for an exemption. You have to come up with a process of how you're going to deal with that individual. You're also going to have to come up with ideas on how there's other potential issues with vaccine, or how will you manage someone who has a medical delay for their booster or their second shot. So just be mindful of that and try to think of worst case scenarios and be prepared for them. Next slide, please. Okay, now we're getting into the fun part. You guys are I'm gonna teach you how to be surveyors for a few minutes. So this is specific to long-term care, and as most of you know, there's something called scope and severity. So severity levels are ranged from level 1, 2, 3, and 4, 4 being the worst, and IJ. So I'm going to give you 3 scenarios of how we can set you in an IJ level. So scenario 1 is that you did not meet the requirement of staff vaccinations, or you don't have policy and procedures developed or implemented. So either you don't have 100% or you don't have policy and procedures is one part. The key here is the and. So if you have like one of those I just mentioned, and 3 or more resident infections in the last 4 weeks resulting in hospitalization or death, that is an instant immediate jeopardy. So let's go ahead and go to the next slide to scenario 2. So you did not meet the requirement of staff vaccination, and 3 or more residents infections in the last 4 weeks did not result in serious harm or death, but one of the following did. We observed infection control issues such as PPE, which is a common citation, or 1 more of your components of policy and procedures were not developed or implemented. Let me be very clear here. It says developed or implemented. If you have it developed and you're not putting it out there in action, you will get cited. If you don't have it developed, that's easy enough. You're going to get cited for that as well. But notice when you read these regulations, the ands and the ors, because that's what's crucial here. Next slide, please. And then this one's pretty simple. After your 90-day compliance rate, or your 90-day compliance date of 100%, if more than 40% of your staff are unvaccinated and there's evidence the lack of effort to increase those, you will have an IJ. Pretty simple. All right, let's go ahead and move on to level 3. This is level 3 actual harm that's not immediate jeopardy. Here we go. We have a lot of ands and ors in here. So you didn't meet the vaccine requirement. You had 3 or more infections in the last 4 weeks that ended in hospitalization or death, and 1 or more of your components of policy and procedures are not developed or implemented. So level 2, please. Next. Okay, so we have 2 scenarios here. You did not meet the vaccine requirements, but there was no resident outbreak. So basically after the 90 days, you're at 99% or 95%. You don't have any outbreaks, you get cited at a level 2. Another scenario would be you did not meet the staffing requirements and 1 or more of your components of your policy or procedures was not developed or implemented. So that's why I said it's very important that you make sure you have every section of your policy and procedure ready to go. And level 1. Level 1. Basically, you met the staff vaccine requirement of 100%. If you didn't, you'll be cited at 2 or higher. But if you have 100% vaccination, but maybe your policies and procedures weren't where they should be, you'd be cited at no less than a C. Okay, let's move on to scope, please. Scope. So basically, I'm going to give you a quick rundown that they're finding that staff with 75% or lower vaccination rate experience higher COVID cases. And then just the opposite, you know, the more vaccinated staff you have, the less likely you have to have a COVID outbreak. Next slide, please. So this is how we determine the scope and how isolated, pattern, or widespread it is. I'll let you read there. Basically, isolated event if 1%, but not less than 25% are unvaccinated. And then it just goes up from there. Next slide, please. Okay, so I wanted to kind of give you guys some observations, subjective and objective, in the field. This is pretty important. So seen scenarios where there's 75% vaccination rate without an exemption process. So you're failing the vaccine requirement. Again, I'm speaking in 90 days, and you're also failing the policy and procedures. The next one is lack of access to employee files. There's been a lot of question about how much surveyors can look at. we need to be able to identify employees and whether they're vaccinated or have a proper exemption. A lot of facilities, not in Alaska, I'm just saying I've heard from the nationwide, a lot of facilities are restricting surveyors from accessing this information, and you necessarily can't do that. We've got to be able to make sure you're compliant. And the third is missing policy and procedure components. Process for exemptions is a big one. Additional precautions for exempted staff we've seen, and tracking failures of not being able to keep an accurate updated tracking device, or excuse me, tracking list. And last thing I'll mention, I have a minute left here, is that vaccinated versus exemption ratio. This is a big question. There is no guidance that says if your vaccine percent is lower than your exemption percent. And the example I gave is we walked into a facility and saw 80% exempted and 20% vaccinated. We're not necessarily going to go through and see why there's 80%. However, we will really closely look at your process and see why the number is so high. This is not necessarily citable for now. I do not know of, nor do I anticipate that CMS will come out with concerns if you have a very high exempted rate, but I'm just letting you know right now, there's no regulations against it, but we will scrutinize your process even further just to make sure there's nothing wonky going on. And I believe, next slide, please. Okay, so this is our last informational slide. I'm going to tell you how to prepare for survey. Some of this is going to be pretty obvious based off what I've told you so far. You're going to maintain a list of your COVID-19 cases for residents and staff. We will look at a minimum of the last 4 weeks. Provide a list of staff and their vaccination status using the vaccine matrix that will be provided to you by the survey team lead. Really important to enter good, accurate, and timely data into NHSN. This is what drives your survey. If your data is incorrect, we could come in with the wrong impression and result in us being on site longer. So good, accurate NHSN data is very key. And obviously ensure that your policy and procedures meet all the requirements established by CMS. And I just went through all the components there. So, and make sure they're implemented. We have seen cases where policy and procedures are developed and they're beautiful and they're well done, but they haven't implemented them yet. So if you're going to do all that work and make a beautiful product, make sure you're using it. And one of the things that has also been questioned, and I want to make this clear to everybody here, every standard survey, what that means, every initial certification survey, every research, your typical annual, or every complaint survey, no matter the topic, say if we're going to complaint for restraints, we are still going to do a vaccine survey on each one of those. Next slide, please. And I just want to say thank you so much for giving me the opportunity to talk to you guys. There's my contact information. And Dana, I don't know if there's any questions or if there's anything we can address now or wait till after Dr. K.
Hey, thanks, Matthew. That was really, really great. Are there any, I don't see any questions in the chat. Does anybody have anything you want to ask Matthew before we hand it over to Dr. Kunzweiler? Let's see, the staff vaccine matrix, is it for only the staff or do we need to add in contractors, consultants, etc.? How is the CMS staff vaccination matrix F888 being used by surveyors? Loaded question.
Oh, muted myself. Vanessa, thank you for your question. If you don't mind, let me do some research while Dr. K is doing his presentation to get back with you on that.
Great, thanks. All right, and go ahead if any questions come up, pop them there in the, we have one real quick one. Would you please clarify the use of N95 guidelines for unvaccinated staff members?
That's really going to be the CDC guidance on the N95. It was just a suggestion by CMS and in this presentation that those could be used as opposed to surgical masks. So if you're masking, your vaccinated staff can use surgical mask, and then your non-vaccinated could use N95s. Are you looking for anything more specific than that?
And nobody's saying you have to put them in. Is that correct? Is that your understanding? Just that's
Yeah.
one of the options that you could do to mitigate the risk for unvaccinated staff members.
For the purpose of this presentation, I was only providing that as an example of going above and beyond, going extra for the unvaccinated staff. I'd hate to sound bureaucratic, but at any given time, whether it be today or tomorrow, you just need to follow those CDC guidance on PPE usage because they do change quite often.
Great. Okay, another question about the F888. So if you want to take a look at that, we'll let Dr. K go ahead and we'll come back to you. Thanks.
Hello, good afternoon. Thanks for having me. I'm going to talk about the types of testing that are available for COVID. In terms of how you use them, I think you really have to look almost daily at CDC guidance, or certainly weekly. It changes as everybody's status changes. But talking about the actual testing itself is fairly simple. There are a couple of reasons for testing. The most important probably is if you have symptoms, you have fever, you have cough, you have sore throat, you have headache, runny nose, you want to test to see what is the cause. And so you should have a COVID test if you are having symptoms, because it could be influenza, it could be respiratory syncytial virus, it could be rhinovirus, it could be any of the other common cold viruses. They all present, especially early on, with essentially the same symptoms. Another reason to do the test is if you know you had COVID-19 and you are wondering if you are still contagious. That would be another good reason to test. And then lastly, to satisfy a requirement either for travel or for work, some governmental regulation that you're trying to satisfy. Next slide, please. So there are basically two types of tests. The first is the polymerase chain reaction test. And this is also sometimes called the nucleic acid amplification test. So you'll see it abbreviated as NAAT, just to make things nice and confusing. So that's one type. The second type is the rapid antigen test. And oftentimes you'll see that just called a rapid test. So these two really work quite differently. The polymerase chain reaction test takes a sample and it looks for very tiny amounts of RNA from the COVID virus. And then when it detects those, it amplifies them by literally millions of times. And then it can demonstrate that data in a way that's easy to read. It is very sensitive. It can detect very small amounts of RNA. It's very accurate. So there are not very many false negatives. If the test is negative, it's very unlikely that you have COVID. And on the other hand, if you do have COVID, it's not very likely to miss that. If you have it, you're going to get a positive test. So it's very sensitive and it's also very specific, which is what you look for in a good test. Unfortunately, it's fairly high tech. It takes a laboratory that's equipped to do this. It takes a technician who's been trained in how to do it. And it often takes more than a day to get a result back. And if it has to be sent to someplace off-site or to another city, perhaps, that's not uncommon. It might take several days to get the test back. Also, as you might guess, it's fairly expensive, in the range of $100 or more. And because it is so sensitive, it can remain positive even after you have essentially resolved your infection. Your symptoms are gone. You are probably no longer contagious, but there may still be very tiny amounts of the RNA from the virus in your system, and it might be able to pick those up. So its primary use is if you have symptoms and you're wondering, do I have COVID or not? It's the best test to confirm that your symptoms are from COVID. Next slide. The rapid antigen test, on the other hand, instead of detecting the RNA of the virus, it detects some of the protein from the virus. And there's a number of these rapid antigen tests, and they detect different types of protein from the virus, but that's what they're looking for. And they have a strip of antibody that will change colors if the protein sticks to it. So it looks a lot like a home pregnancy test. They are not as accurate as the PCR tests. They need a fair amount of protein for them to be positive. So that being the case, there are going to be more false negatives. In other words, you may actually have COVID, but if you aren't putting out a lot of virus, a lot of the protein from the virus, it may not detect that. On the other hand, if it says that you are positive, it doesn't have very many false positives. So if it says you have it, you most likely have it, and you are most likely contagious, which means there's a lot of virus in your system. Now, the advantages are, as the name implies, it's rapid. It can be done in a matter of minutes to an hour or so, and it's also relatively cheap, in the vicinity of $15 a test. And it can be done at home, just like a pregnancy test can be done at home. You don't have to have a tech, you don't have to have a laboratory. And its real use is if it is negative, even though you may have had COVID, or you may now still have some of the virus around, if it's negative, you're probably not contagious. Next slide. So the bottom line is that if you are symptomatic and you're worried about what has caused it, the most accurate thing to do is to use a PCR test. If you know that you have had COVID, then the rapid test is useful to help you determine whether or not you're still contagious. So if you think you've been exposed, if you do the PCR test fairly soon after exposure, and you do have the virus, it's going to tell you that. On the other hand, with the rapid antigen test, you're going to need to wait a couple of days before it's going to have very much accuracy. So testing a couple of days after your date of exposure, and then maybe testing a few days even after that with the rapid test are going to be the best way to tell whether or not you've actually got it. Next slide, please. So this rather complicated looking algorithm actually is fairly simple. This is available at CDC's site. And there are two scenarios. On the right-handed side is if you are symptomatic, and on the left-handed side is if you are asymptomatic. And it gives you a map to follow if you have either a PCR test or an antigen test. And that, as you follow down through these various arms of the algorithm, it'll tell you what your next best recommended step is. And it gives you guidance for follow-up then at the bottom there. So two main types of tests, one very sensitive, very specific, also very expensive and time consuming, one cheap, not as sensitive, pretty specific. And the uses then are, if you really need to know whether or not you've got the COVID, you want the PCR test. If you are wondering whether or not you are safe to go back to work, to go back to school, then your rapid test is your best bet. And I think, next slide, I think that's it, unless there are some questions or something else I can help you with.
Do you have any questions for Dr. K?
Yeah, and in regards to the CDC guidance on testing, it really has changed over time. So, the best bet is go to CMS or go to CDC and see what they currently want you to do in regards to testing right now. The free tests, my understanding of those are all rapid. Now, there's also a CDC site that will list the various companies that are making the rapid antigen test. Some of them are pretty good, others are not so good. Some have been withdrawn from the market. And if you're wondering about the test that you've got, you can go to the CDC site and look up the manufacturer and see how they're rated at the present time.
Oh, I did not know that. Thank you.
Yeah, there's about a half dozen different rapid tests available.
Mhm.
Off the top of my head, the Roche test is pretty good. There's a couple that are not very good at all. But again, that's something that is not static. It's changing, from week to week. So I would go to the CDC site and take a look and find
Jeff, we're not used to that by now. I. All right, Matthew, did you find anything for us?
Yeah, you can hear me okay, Dana?
Yep.
Yeah, so there was a couple different questions that came in and I was frantically trying to get a good consensus to respond. I believe one of the questions was about the matrix. I did confirm with my staff that the matrix is optional. So it's not a requirement and surveyors shouldn't be requiring you to fill out the matrix. You are allowed to provide an Excel sheet that you're already established to do that, and that will supplement the matrix, which makes sense because I looked at the matrix and there's only like 20 slots for names. So you're gonna have to supplement it anyway.
Yeah, that makes sense. Thanks.
And then let's see here. I'm trying to go back through the chat here to see what other questions there were.
Did we, that was Diane, did we clarify the N95 for you?
Yeah, Diane, did you need more specifications on that, or specificity, I mean?
Sorry, I'm trying to unmute.
No worries.
I was just reading. No, Marcy, we've been having conversations here in Montana in regards to the N95. And from what there is a disconnect in conversation, and I just want a clear understanding that CDC has put out their recommendations for source control versus actual PPE for those patients or residents that are either exposed or have COVID-19. And then you have what we heard, and I could be misinterpreting this whole thing. What we heard from the CMS part of it is that that all unvaccinated employees, no matter if they're treating an exposed or a COVID-19 patient, will need to wear an N95 mask. And our state surveyors, from what I have, and correct me again if I'm wrong, are going to opt with the CMS guidelines, which is great. But I just want clarification. And from what I heard, that it is an option as long as we are able to provide those resources to unvaccinated employees. We are good to go, but they are not mandated to wear them at all times.
Yeah, so I was looking here and I'm only speaking to the QSO memos. I'm not looking at CDC. I'm not looking in anything outside of the vaccine mandate QSO memos. The way that it reads is it states there's a variety of actions or job modifications a facility can implement to potentially reduce the risk. One of those options was to utilize N95s when available for those unvaccinated people or not fully vaccinated individuals. And as far as this QSO memo goes, I do not see that as a mandate. It's only as I mentioned, going above and beyond, so to speak.
Okay, perfect. Thank you so much.
Great. Thank you, Matthew. Anything else?
I believe there was one more question, Dana, if I
Okay.
may.
Yep.
Let's see, it was, the staff vaccine matrix is, do we need to add in contractor consultants? Yes. So the actual matrix itself does include people under contract or MOUs or agreements. So somebody gave me a good example. If you have people coming in to do PT from another facility and they're performing those cares, they're a contractor under agreement, so thus they would have to be part of your listing as well. Does that help you? That was Vanessa, that was you.
Vanessa.
Help?
Oh, was that her that just popped up?
Okay,
Okay, good.
great. If there are any other questions that I missed, I guess now would be a good time to let me know.
And you can also send them to, any one of us, whoever your Mountain Pacific contact is, and we can get those answered and include those in our FAQs for next time. Looks like we've got an evaluation link in the chat. So we encourage folks to click on that and complete the evaluation. I really want to thank Matthew and Dr. K for a couple of really great meaty conversations here today. So thank you guys very much.
Very welcome.
It was a pleasure.
All right. Thanks, everybody. Take